Welcome to the LifeBeat podcast, a One Joshua Group production, providing access to information and experts to improve quality of life and health outcomes.
Hi, I'm Kermit Payne, the host of LifeBeat, and thank you for joining us. We always appreciate you taking the time to listen to our informative, innovative, and oftentimes surprising information. But remember that LifeBeat is a resource opportunity for you, our viewer, and our listener. I'm excited today and very honored to have as our guest Dr. Sandra Maass-Robinson. Dr. Robinson has spent much of her time in private practice in Atlanta. She has participated in many national and international disaster relief programs. Right now, Dr. Maass-Robinson is involved with clinical trials in mental health in our community to improve health and life outcomes. Dr. Robinson, thank you for joining us.
Thank you. My pleasure, for sure.
So I have to tell you, and Dr. Robinson and I spoke, she and I have known each other for more than 4 decades. So that's important. Longevity has its place. I think we talked about that. But in friendships and in relationships, it's really important. This gives us a chance, Dr. Robinson, to talk about your current work in clinical trials. We know that there is a disparity in participation of patients, particularly patients of color, in clinical trials, which means that providers also are lacking in the numbers and participating in clinical trials. How do you suggest that we become, both as patients and as providers, more integrally involved in clinical trials, particularly within the psychiatric discipline?
Well, in essence, that question gets directed at a more critical component, and that is how do we encourage our community to become more involved in their care and to become more, I don't want to, the word isn't aggressive, but more persistent in working with their physicians and nurse practitioners to find out what's going on in the world and what is there that's available to me to become more engaged in my healthcare. And that's really a basic step that unfortunately for most of us, we've been led to believe that we really shouldn't speak up the way in our own interests, and consequently we miss out, and we miss out on a lot. Clinical trials being one of those areas, because physicians for the most part will not think of referring you to a trial, and you don't think of asking. And this is information I learned later in my practice, in my professional career. I did see trials for the longest time as something that they were doing with a certain population, and I would have to extrapolate the data for my patients. But I later learned that part of that certainly is the selectiveness of trials, but the more that we're engaged in it, the less selective and the more inclusive they become. But it really does start with the individual, the patient, for having the ability and the confidence to ask about other treatments. Is there anything else? I think one of the areas that we're most familiar with in terms of actual research is cancer trials, and there's a lot of them going on now. So I'm seeing a little more willing to ask, are there any trials that could help me in treatment? But I'm not involved in clinical trials with cancer. I'm involved in clinical trials for psychiatric medications, and that is an area that, particularly for minority populations, et cetera, there's the bottom of the barrel, and then there's up under the barrel. And I've always felt we've been up under the barrel on that. So being involved in these trials and seeing the possibilities and knowing that we can move from medications that have been effective but loaded with side effects to medications that can be more effective with fewer side effects. And that's the goal, the trials that I work in.
So there are two things that you've mentioned that you and I've had discussions about. Outside of awareness of the opportunity to participate in clinical trials, being willing to prompt your provider, your physician, to ask, are there other methods of treatment? Clinical trials is a method of treatment that's available to me that I can participate in. Are there other barriers that we don't talk about that could increase both participation by physicians, our providers, and for patients?
Well, certainly there's the historical component. So we can't even go forward without giving value to that. And not only have we been not we have not been embraced in terms of the need to be a part of it, be at the table when it comes to trials, but there are historical events, and again we go back to the Tuskegee experiment, which really does get confused. That was not a clinical trial.
It was not a clinical trial.
But we think of it that way. It was just simply a group of gentlemen were exposed to a disease, and that was the end of it. They were not offered treatment when treatment was available. And that's not a clinical trial by any means. So today's trials, at least what I have seen where I work, and I feel I can say without hesitation that the diversity of the company, the inclusion of study participants, and just the researchers and the teams themselves, it's a good feeling to work in such an environment. And so that being one thing, that we just didn't trust the system. And I'm not suggesting we do a lot more trusting right now, but if we know where to look for the right answers, we can engage. And there is you can do a search on the internet, and I don't have the exact link, but it's clinical trials, and you can drill down to where you are and how far you'll go. But there's a lot more information out there. I don't think we're either provided it or aware that it exists to do just that, to become more involved in them.
Yeah, trust in clinical trials, we always see that as a barrier, but something that you shared with me, and that is, as a patient, as a consumer, I believe that we can become more trusting if we are more informed. So I just want us to own some of that trust and not give our trust away to someone else. I think that just makes us more comfortable. A lot of times we're not trusting because we don't know. We don't we don't have enough information to be trusting. So the lack of trust is not just in the clinical trials. It's not just in the providers. It's we don't know what the outcome are, what the outcomes could be. So that's the component about trust. You mentioned side effects, and I want to ask you about side effects from participating in clinical trials, because I understand that is one of the barriers for people not wanting to participate in clinical trials.
Well, and again, anything you ingest in your body or you take in has the potential for a side effect. So whether it's a Tylenol or a psychedelic prescribed medication, there's a potential for side effects. And I say that to patients all the time. They want to know the side effects. I can go down the side effects, take out the package insert. It's 4 pages long, potential side effects. And I am a big quality of life person. Treatment is not worth having if it destroys your quality of life. Quality of life is dependent upon the absence of side effects, along with the benefits from the medication. So one of the responsibilities of any clinical trial is to be able to fully describe to the study participants what has been seen so far in these trials as potential side effects. And the majority of this, and we're looking, and the trials are looking to see what else is being generated. And let me just say as an aside, I don't think people understand when the protocol for these trials can become so strict. You can't do this, you can't be on that, you can't have this history, you can't. That is to eliminate any possibility that what we're seeing in side effects can be attributed to something else. So you come to your next visit and you had an infection and you went on antibiotics. Oh, I forgot to mention that. Okay, so maybe the headache you're having now is from the antibiotic and not the clinical trial. Yeah. So it's the need for full transparency and disclosure, and that comes from the trust. So, but I think it's so important. I think it's also worth saying that these trials, the majority of them are, the majority of them are double-blind, placebo-controlled. That's so difficult for me. First of all, I have to learn how I engage with the subjects because I'm ready to, pump up the volume and the potential value for conditions that they haven't been well treated for, and hope that this will be it. But that's not the purpose of a clinical trial, and that's certainly not the purpose of an investigator. Have to be neutral on this. But when you see that change and that people are benefiting, it's for some in a situation where they've never been well treated before. It's a beautiful thing.
So what is double-blind placebo control?
Oh,
What is that?
DBPC. That is just, you're going to get a pill, and I don't know what you're getting, and you don't know what you're getting, and it could be the placebo, and it could be the actual, what we call IP, investigational product, but neither of us know, and nobody knows except the pharmacist, and they're blind. We're blinded to everything else. So when you see, and this is the thing, we know how powerful the placebo effect is. So if you're in an 8-week trial, and the first couple of weeks, the subjects come in and I'm feeling better and this and that. Of course, you're thinking, well, maybe they're on the drug. Then a couple of weeks later, it's not working as well. Probably on the placebo kind of thing. So it's just the nature of the trials as to how the effect nets itself out. But we have a lot more of our trials now going to what we call open label. So you go through the double-blind phase. It's usually 8 weeks, and then you're eligible based on some components to go into the open label, and the open label is the drug itself. And switching to that, and people finding now that I am feeling better is motivation as well. Let me say one thing before I forget. It's so important. I so honor people willing to engage in clinical trials. I mean, you just have to know it's a tedious commitment. I mean, there are short-term trials. We did vaccine trials, and some of those were much shorter. But it's tough. And yes, people get reimbursed, and they should be reimbursed for that. But it's a tough commitment, particularly open label, when that's a year-long commitment. So I just want to say for anyone who happens to be listening that has been in trials, I honor your ability, because we couldn't do this without them. Bottom line.
Yeah, you've said something that I know that we all have to be better about, and this just recently happened to me. I am hypertensive. I have high blood pressure. I'm not hypertensive. I have high blood pressure. So those are two different things. So, and I ran across a clinical trial, and I asked my primary care physician, well, what about this? And, he kind of blew me off. And so I'm not the person you blow off. And he says, well, something. So what I really found out was he didn't know anything about the clinical trial. But I wanted to know, and that's something that you said, we have to advocate for ourselves for better health. We cannot leave better health advocacy to a doctor or a lawyer or whomever it is that's participating in that care. So it is your body, it is your mind, and so we need to be better advocates to improve our mental health. It's also very interesting in some of the people that we've talked to as our guests. So from a cultural perspective, as you mentioned Tuskegee, so that's about sex. And then we're talking about psychiatry, that's about the mind. And in our culture, those are just two things you don't talk about. You don't talk about sex, and you don't talk about the mind. Are there cultural barriers around clinical trials, particularly as it regards mental health, that may affect some specific populations because of beliefs or myths?
Absolutely. And I think there's the plus side and the minus side. The minus side being that we overpopulate our people of color overpopulate the diagnosis of thought and mood disorders, especially schizophrenia in various forms. So the clinical trials tend to have a higher number of people of color in those trials because just by virtue of the fact that that's the diagnosis.
So that's
that most
unusual.
but it is what I see. On the other end of the spectrum, particularly in our psychedelic trials, the population is not representative of, even though we represent about 5% of the population, and maybe 15. Well, I think it's the other way around. 15% of the population, 5% in clinical trials, were not in the psychedelic trials, and that I think has partly to do with just the misgivings and the stereotype about it, and then the others that we don't have access to that information and we're not referred for that. So that's two ends of the spectrum. And the issue with regards to the psychedelics in particular, and we can talk about that a little more, but the issue with that is that they're being used around the world legitimately. We are in a culture, I don't have to say anything more, that does not value both the historical components that go into why psychedelics have been used, for centuries and centuries, doesn't value that, and then allegedly carries us through all of these loops to make it okay. That being said, it's still now clear that particularly with so many conditions, and treatment-resistant depression is one of them, generalized anxiety disorder is another, PTSD is another. These are conditions that people leave this country to go and get treatment for, very effective treatment, that we're finally doing something here for that. So that it's such a melange of reasons and access and understanding. And I was recently at a conference when I was speaking to a group of Black psychiatrists who were just kind of like, are these trials safe? And really questioning the safety of them. And it's like, yes, why would you ask that they're not safe? I mean, all trials are supposed to be safe. Allegedly, I mean, are there problems? There have been, but I think they're much better controlled now. So that said to me, do you really understand what the clinical trial is required, what the protocols require? Because when it's done and it gets before the FDA, we've already seen some of these trials, the psychedelics have been denied because their data and was not clean and it was not well monitored. So I think that is it's a disservice to us not to become. When I say us, particularly providers and healthcare providers, not to become more aware of how they can be helpful and their safety, and then to see if their patients would benefit from it.
July is Minority Mental Health Awareness Month, a time to talk about the mental health needs within the Black, Latino, Indigenous, Asian, and all communities of color. For too long, stigma, lack of access, and cultural barriers have made it hard for many to get the care they deserve. But our mental health matters. Our stories matter. Mental health is just as important as physical health, and healing isn't weakness, it's actually strength. Talk to someone. Reach out to a trained, qualified counselor, support a neighbor, a friend, a family member. Advocate for culturally competent care. There is power in breaking the silence. Not only in July, but from now on, let's lift every voice, break every barrier, and make mental health care a priority for all.
Well, we've talked about your professional career now. We'll talk about, I know about that part, but also the Saundra that I know has a considerable service component to her personality and to her spirit. So I want to thank you for the service work that you do as well, and also to have you take us to the place where you participated in some of the disaster support. And what your role has been, what kind of work, what you've seen, that you can tell us what you've not seen, and what that's provided for you as a professional, looking and being involved in disasters. Can you share some of that with us?
Yeah, it was interesting because my first disaster, and I joked with some of my colleagues with that back, and I think for Hurricane Hugo, and I know I'm dating myself if I could even remember that, but Hurricane Hugo, which hit the Caribbean, and then it ultimately hit Charleston, and people have that very clear memory of it, 1988, 88 or 89, something like that. A group of African-American physicians came together because one of the docs here, his home had taken a direct hit in St. Croix. So we kind of pulled it together, just, serendipitously, and went down there, spent about a week manning clinics and helping out. And one of my first, and I'm a psychiatrist, but I'm first and foremost a licensed physician. And that's what I like about the way I've defined my career, is that, this is my specialty, but it does not isolate me from medical knowledge, et cetera. So I'm down there working, and I'm doing cut and paste in the triage thing and my very first patient was the only psychiatrist on St. Croix who had sliced his leg trying to get the tree out of his driveway to go. And I'm saying that to say that his concern was, I need to hurry and get back and start working on the disaster stuff. And I asked him, so what do you do as a psychiatrist? And this was my first disaster experience. He said, whatever I can. And that, and I said, yeah, that's what we can do. I mean, you don't have to be, an orthopedic surgeon to fix the bones. I can prep them. And what I've found from that is how the misconception that the only thing psychiatry can do is talk to somebody about something. And that also was around the time that psychiatric medicine was being, at least within the specialty, becoming more integrated with regards to whole body medicine, and to seeing it as that integrated specialty. It's taken a while to get there, but that led me to see that, first of all, how much I could do, because with my knowledge and training as a psychiatrist and seeing victims of disasters, you're looking beyond the actual wound there, and you're looking at the whole person and beginning to understand what's, how this is going to impact them long term, and then begin to offer the one thing that coming out of a disaster people need. And the one thing is that there are options. The feeling that I've lost everything and there are no options here. And interestingly enough, that's the way psychiatry works too, especially in any condition, but when you're working with patients who are feeling so depressed and suicidal, it's because they don't think there are any options other than that. So that whole, I call it my options-based medicine, is in any of these settings and where the individual just doesn't see beyond, your role is to help them to realize there are options, whatever they may be. And so that was my first disaster. Ending up, the disaster that, of course, for me was one of the most memorable, was volunteering to go to the South Pacific, to Indonesia after the tsunami of 2004, Christmas Eve. So Massachusetts General, the U.S. Public Health Service, and the U.S. Navy had put together volunteers. And what surprised me about that is they asked for psychiatrists. And again, this was still at a time when people didn't know what the role of psychiatry should. Well, we'll send them to you after we fix them up, and it's not the way it should be. So I was the only psychiatrist, and I just raised my hand, and just off we went to Southeast Asia. And again, it's what people say about disasters here that we're experiencing, which I saw back then, is that how totally devastating they are. We get everything, the hurricanes and the tornadoes and the floods and wildfires, and they are devastating. But they're now of that magnitude of devastation that others have experienced in the past. And that's what the tsunami of 2004 was. It was total devastation. And I will say my takeaway from that, aside from being able to engage with patients, and the Indonesian government was so generous, especially in the interpreters that they offered us, who could, that's being able to interpret when you're dealing with not this, where does it hurt and this and that, but just the whole emotional component. They were very, very skilled at that. But the one thing, there was a woman who was brought into the ship. We were on a hospital ship, and she, in the course of being triaged, she wanted to know if there was a psychiatrist around. You have to know the population of Sumatra at that time, which essentially was pretty well controlled by and the name escapes me, the group of individuals who were seeking to break away from the Indonesian government. So that didn't put them at the top of the list of the government to provide help to. But and these are rural people, and these are folks that just living out a good life, and it was a predominantly Muslim culture there. Okay, all that being background, but this woman asked for a psychiatrist, and I thought, oh my goodness, what am I going to do here? And so went to meet with her, a beautiful woman who had lost, we say lost everything. What does that mean? Because families there are so multi-generational and remain connected. When you lose everything, you lose aunts, uncles, cousins, brothers, sisters, everything. So you can have a family of 30, 40 members, and when they're it's everything, that's an everything. And she had pretty much, and she'd been found floating in the ocean, holding onto a tree, and she'd lost everything. And I'll be honest with anybody, I wouldn't know what to say in a situation like that. But you learn in working with disasters, it's not what you say, it's really how you hear what they say, and what you do with that. And the point she made that has become kind of a foundation is that, the life that I lived is gone forever, and I have to learn how to live a new life. And that was my takeaway that has been with me going forward in any disaster advisory or work that I've done is how do you do that? So that's my long-winded answer to your question.
As I said, anybody can Google any of our guests and they can find all that. But because just knowing you for 4 decades, many of those things I remember. So
Thank you.
we thank you for your service, and you've got all my questions. We know now part of what you mentioned, we're learning about PTSD is not what we thought it was anymore. It's not situational, it's circumstantial now. Did you want to comment on any of that?
It's not just the result of war trauma and combat trauma. Trauma is the operative component here, the source of the residual disease, and it's hard to imagine. But I say to folks, it's a heart attack of the brain. And think of that. The brain is an organ just like the rest of the body. It's got a lot of responsibilities in that. But if you're going to traumatize it, just as you would traumatize, with a heart attack or, break a leg, that's trauma. And it leaves its scars. And the scars in the brain are different than the scars, from a knife wound or something. You can always see it there, and it's there, but it begins to dissipate. Well, with PTSD, those are scars that it's very hard to just, you cannot just ignore them is what I'm saying. You can, but they don't go away. And the treatment for PTSD is about recognizing that while we can't eliminate the scars, we can definitely temper and to a large degree minimize your reaction to that. So and with that understanding, we are moving forward in a number of areas with extremely good treatment for a condition that forever has been misunderstood. And of course, now we're recognizing even in children, who live in environments that are constantly violent and threatening, and this it leaves its scars. So it is one of those conditions that we're finally paying the attention to it across the spectrum, so that everybody should get a chance at fair treatment.
So finally, and we thank you for making us feel a little lighter today. I feel more encouraged just by having a conversation. So listening is important, talking is important, communication is important. What would you like to leave with our viewing, listening audience from the time we spent together today?
Just, well, as you've pointed out several times, you know me well, and it's not easy for me to wrap things up into a 30-second takeaway. But but I just, with everyone, it's your life, and I really want us to, in spite of the roadblocks that are consistently and continually and historically thrown at us. We have a history of getting past those roadblocks, and we are now looking at the emerging, particularly the emerging role of psychiatric medications to better our life. And I would, if you don't do anything except the fact that it's a disease, psychiatric illnesses are diseases in the brain that manifest themselves generally in behavioral and thought patterns. Seizures are diseases of the brain that manifest themselves in motor abnormalities. Alzheimer's, it's a disease of the brain that manifests itself with cognitive problems. They're all up there. And psychiatric diseases are no less important than a stroke. So if we, as I say, in our communities, could move beyond that stigma. And the one thing I would say, and stop referring to people who are showing any of these abnormalities with that C word. I just absolutely abhor that. There's some words out there, and we all know one of them, the N word. The C word is the same to me. It really invalidates and devalues a person's struggle. So that's the one thing, let us become more embracing of ways to feel better and take that responsibility, because, not everyone's listening to you quite the same way as you are feeling. So empower ourselves. That's what I want.
Well, thank you for your time.
Thank you.
And thank you for joining us. I'm Kermit Payne, and I'm the host for LifeBeat. We've been joined by Dr. Sandra Maass-Robinson, renowned psychiatrist. She is a life enthusiast, and I cannot wrap up what she said clinically, but from life, I can tell you, she said to us that we can move beyond trauma, the scar of trauma, if we believe that we can take the lessons that we've learned to move forward. Thank you. Remember to be kind to others, and most of all, be kind to yourself.
We would love to hear from you. Send your listener letters, questions, and topic requests to media@the1jg.com. LifeBeat, the podcast, is sponsored by One Joshua Group, your strategic source for engagement to improve life through better health, education, and information. To learn more, visit us at the1jg.com or follow our work on social media using hashtag 1JGCollabs. One Joshua Group, advancing access to healthcare and education by joining what you know with what we've learned.